Okay, so maybe we'll get started. It's 5:01. So I want to welcome all of you. My name is Tim Pollock, and I'm the president of the America's Hepatopancreatic Biliary Association. And we're very excited about this webinar tonight, where we have a wonderful group of moderators and panelists who will be discussing some challenging cases in the area of pancreas, liver, and the biliary tree. And we've had two other successful webinars, and I have no doubt that this one will be equally as successful. I will ask that if you have any questions, that you put them into the chat room, and we'll continue to monitor your questions, and our moderators will try to address as many of those as we can. At this point, I'd like to introduce Dr. Shah. Dr. Shah is professor of surgery and director of the transplantation program at the University of Cincinnati. And I want to thank my good friend Shimel for really being the individual who organized tonight's webinar. Shimel, thank you so much.
Thank you, Tim, and we're looking forward to a great night. For the speakers who are not going to be part of the first session, you can turn off your camera and just remain part of it. You can join in the chat room, and then that way we can highlight the moderator and the first three panelists. The moderator of the first session is going to be Dr. Katie Morgan, who is the professor and chief of GI and laparoscopic surgery at MUSC. And then she's going to manage our three panelists, expert panelists, who include Jessica Chaffee from Piedmont in Atlanta, Nick Zaromsky at Indiana, and Chad Ball at the University of Calgary, three people we all know well. Katie, the floor is yours. Excited to hear your case.
Thanks so much, Shimel, and thanks, Tim, for having me here today. I'm excited for our expert panel. Let me see if I can get my screen to share with you all. Let's see. There you go. Great. Okay. So as Shimel and Tim have introduced, today we're going to be talking about the management of some challenging HPB cases, and we're going to talk for the next little bit about a pancreatitis case. I think as I thought about what case to bring up, I thought maybe we should do something exciting and pretty, but then I remembered it was pancreatitis. And so it's inherently messy in this case. I think we'll show that, and maybe not exactly display our perfect management, but a lot of messiness. So our expert panelists, as Shimel introduced, are Dr. Ball from Calgary, Dr. Chaffee from Piedmont and Atlanta, and Dr. Zaromsky from Indiana. And hopefully these guys can make better decisions than I did in managing this case. So the case is a 61-year-old gentleman who presented with gallstone pancreatitis. He had a 4-week hospitalization at an outside hospital, 1 week of which was in the ICU. He had new onset AFib with rapid ventricular response. He had an acute kidney injury, which resolved. He had new onset diabetes that developed. There was a question of some SMV occlusion during his course, and he was found to have gallstones as well as a history of alcohol. And so the exact etiology wasn't clear, but both of these were sort of considered. So he was discharged home from that hospitalization, but came back 3 weeks later with jaundice. And at that point, he was transferred down to us for further management. His past medical history is significant for hypertension, gout, and reflux. He had no past surgical history. And when he came to us, he was afebrile, stable vital signs. He was in no distress. He was deconditioned as he had a 30-pound weight loss over his illness. His white count was normal at 6,000. His creatinine was 1.2. His acute kidney injury was resolved. His total bilirubin was 4.5 with a direct of 3, and his alk phos was elevated, and his albumin was 2.7. So this is the CT scan from his initial hospitalization at the outside hospital. Move on to the next. And then this is what the CT scan when he came to us. Again, this is 3 weeks after his discharge from that initial hospitalization. And so I'll stop there and bring our panelists in on this and see, I guess first, Nick, Dr. Zaromsky, what do you think about this small rural South Carolina hospital managing this patient for the initial portion of the hospitalization?
Well, that's a loaded question, Katie, because I practice at a quaternary referral center and we have all the modalities. But I think that the good point is that people with necrotizing pancreatitis have a long illness, 5 months on average. They often require complex interventions and multidisciplinary input from interventional radiology, from experienced advanced gastrointestinal endoscopists, from pancreatic surgeons. And so I think that access to a full team of people to help manage this type of patient is really imperative. Having said that, we get referrals from all over the state of Indiana, much of which is rural, and we do a lot of phone consultation and video consultation in this day and age. So just making sure that there's one physician driving the bus too is really an important part of the process, in my opinion.
Great. And then Jessica Chaffee, what do you think about the next steps for this patient?
Well, I think down the road, I think that this patient needs surgery, but I don't think he needs it quite yet because I think he's probably pretty malnourished and overall deconditioned. And so I think that we need to bring him into the hospital and get him some nutrition. I would prefer via a drop-off tube and give him some enteral nutrition and kind of wait a little bit at that time. That would be my next step.
Dr. Ball, any thoughts?
Not a lot to add. I think both of those comments are really strong, and you know, we do have to remember, as you point out, this guy's been in the hospital for quite a while. He's had a long inpatient stay, as you point out. He's debilitated, as you mentioned, and he's got some significant comorbidities, probably with not a lot of physiologic reserve. So optimizing him would be good.
Great. All right. So the way that our access often happens is that he was sent down to us because he developed obstructive jaundice. And so he was brought in through the therapeutic endoscopist. And so he was brought down, I think, directly from that hospital to their interventional suite, and he underwent a biliary stent. And while he was in there, the therapeutic endoscopist that did the ERCP also put down the endoscopic ultrasound and noted that there was a lot of necrosis and burden of disease in the lesser sac. And so she called us and got us on board, feeling that there was too much burden of necrosis for them to consider endoscopic debridement at that time. Let's see, sorry. So I guess, Dr. Zaromsky, I guess first the question, what do you think about entry here? What does your team look like that manages pancreatic necrosis at Indiana?
Well, I think one thing that we need to get a little better handle on is, what does the patient look like? I mean, the patient was transferred with jaundice. Are they able to eat anything? What sort of efforts? I like Dr. Chaffee's idea about alimenting the patient. What sort of efforts have been made to aliment the patient? And just because somebody has necrosis doesn't automatically mean that something needs to be done right away about it. I would reserve that for somebody who's symptomatic, or particularly if you think that there's a concern for infection. So I again, like Jessica, and I think Chad may have alluded to this already, I would probably drag my feet for as long as I could, unless the patient was really spiking fevers.
Okay. All right. And so what we did at this point is, is we sent discharged the patient home, as you said, and planned on some follow-up in a few weeks back in our clinic. But unfortunately, he went home but returned 3 days later, which was, of course, a holiday weekend. And our bariatric surgeon was on call for our team, and there was a different therapeutic endoscopist on call. At that point, he came in because he was febrile to 102.5 with a heart rate of 112, white count of 11,000. his bilirubin had come down. It was 5 or high 4s when we saw him a few days before he had a stent, and it was down to 3.7, although that is still elevated, obviously. And here's a new CT that he got in the emergency room when he came in. So now what? Dr. Ball, what would you like to do?
Yeah, that went by pretty fast, but I didn't really appreciate there was a ton of difference in the volume of the character of the necrosis compared to the previous CT. Is that accurate or inaccurate?
Yeah, no, it looked very similar.
Yeah, so I would assume that he's got low-grade sepsis from some etiology, and of course we all know what those causes can be. They're broad in terms of differential. I would start to work that up.
Dr. Chaffee, anything you want to add?
Yeah, I think that's very valid, but I think we also keep in mind he just had an ERCP 3 days earlier, and so the potential of them infecting that necrosis is pretty high. So unfortunately, I think that is going to make me I can't drag my feet much longer. I still think I would tank him up and put him on some antibiotics. I'd be planning on an intervention within a week or so, preferably like 10 days.
Dr. Zaromsky, anything to add?
I'm with the other two panelists. I would get a full evaluation. I'd go back and look at the ERCP and talk to the endoscopist and see if they inadvertently got into the pancreatic duct or not. And then, like the majority of the time when the necrosis gets infected, you'll see gas in the necrosis, but there's a substantial percentage, maybe a third, where you can have infected necrosis without any overt radiologic signs. So I think Dr. Chaffee's point about the recent ERCP is important. The first step, I think we sometimes tend to forget, the first step in the step-up approach is to give antibiotics. But I wouldn't necessarily just start antibiotics without making sure we got good broad cultures. He had a left pleural effusion like most people do. That may turn into a pneumonia. I'm sure he's got, I don't know what the line situation is, but don't forget the basics from infection standpoint.
Yeah. So he was an outpatient, didn't have any lines or other source of such as that. But we were worried. I was worried because his bilirubin was still up, that maybe his biliary stent wasn't working or he had some level of biliary sepsis. And the stent, if you looked at the images or looking more closely at the images, the stent was a little bit wonky. So I wasn't sure that his biliary tree was draining well. And I was also worried about secondary infection of necrosis from the ERCP. And he was pretty sick. He had, a high fever, tachycardia, and had sort of, as Chad said, maybe low grade, maybe mid grade sepsis. And so was worried about a little bit, not true hypotension or not on pressors, but was worried about him. And so he went to the endoscopy suite where they interrogated his stent, saw that it was draining well. And then if you can see on the right, I don't know, I have you guys are in the way of this. I can't, maybe there's some stents here. He placed 2 pigtail stents to across the stomach to endoscopically drain the necrosis. I'd love to hear your opinions on that, some opinions from the panel on that.
Where was the surgical team in terms of conversation about management of the necrosis? Were you in this loop up front, or did you find out after these double pigtail stents were in the lesser sac?
Yeah, this was sort of as I said, the bariatric surgeon was on call, and so I wasn't in the loop on this. But I think this really follows a lot of the GI medicine literature about transgastric drainage as a first step in the step-up approach for them rather than a percutaneous drain. And so the idea was to, similar to a perc drain, to control the sepsis with endoscopic drainage.
Well, I think the important point is controlling the sepsis at this point means evacuating all the solid necrosum. And so once this step is taken, the clock is ticking and they can't just sit back and wait for a couple of weeks to do another endoscopy. The previous endoscopist was worried apparently about the volume of necrosis. And so there's a little bit of disconnect in between those two colleagues. But I think the main take home point is once you intervene, if the necrosis was not infected before, it is now. And so that's going to be a catabolic focus, and it's imperative to get that infected. Could I ask really quick, Katie, respecting time, because I know we have a strict timekeeper, Dr. Falk, I'll take a little sidebar and ask about the incidence of biliary sepsis in this patient. Bilirubin is coming down, but it's not totally down. The guy had a little bit of renal failure. He had a lot of air in the biliary tree. They it looked like a metal covered biliary stent, which don't necessarily occlude all that quickly. What other tips do you guys have about trying to sort out whether this is cholangitis or biliary infection, which is a really common and really complicated thing to sort out? So Chad or Jessica or Katie, any other tips there? Nobody's biting.
A lot of quiet. I mean, I think that was our big dilemma. And I don't know that any sort of non-invasive imaging is going to help you. I mean, he had super high fever, and that's what worried me. And he looked, tachycardia, a little bit of chills. And so he did clinically, it sounds like, look like biliary sepsis. So.
Do you guys measure CRP? Do you guys measure that in Canada or Atlanta?
Yeah, we do. I clearly don't think it's gonna really drop you on one side of the fence or the other, though. But it might be helpful. But I think you've hit, Nick, all the relevant and important points, and a lot of it in this gent is history taking, plus the metal stent issue that you brought up. So it's tough. There's no doubt. And I love what you said about the disconnect between the two endoscopists, and you really made the point that if this wasn't infected before on the necrosis side, it sure is now, and so you got to get moving.
I agree. And then if you also look at where looking at this whole location, so two things about this jumping to transgastric drainage or endoscopic transgastric drainage bothers me. Number one, the etiology was his gallbladder. He needs it out anyway, so that could have been done with one anesthetic event. Number two, the location of the transgastric stent looks pretty high up and not exactly at an easy location if we had to convert this to a surgical transgastric debridement. So on both of those things, I would address with our endoscopist.
That's a sharp observation, as you'll see in a minute. So I came into this after the holiday weekend, and let's see if I can get it to move forward. And he actually had defervesced, looked great, was eating, and had kind of cooled him off. And so we discharged him home on antibiotics, and then brought him back the next week for surgery for lap chole and a lap transgastric debridement. And this is
onto the biliary case.
This is not a picture of his debridement. And I think that Jessica hit the nail on the head, and that these stents that she noted are so high up. There was no CT scan. There was just this one image, and I was hopeful. But when we got in, the stents were super high up. And I planned on hopefully converting this, using that to make my access to the necrosum cavity, and couldn't use it, couldn't get the angle laparoscopically. And the other problem is that he drained a lot of the fluid. And so there wasn't that nice mound of, pushing the posterior wall of the stomach up to guide where to do my necrosectomy. And so it was not the best transgastric debridement, somewhat unsatisfying. But again, he did great. He jumped up and ran. He started eating much better, and went home on post-op day 4. Looking fantastic.
Katie, you started out the case by saying maybe that the others could manage it better, and I think you guys managed it perfectly. Quite honestly, you had a couple of hands behind your back from the get-go, and and that was great. The only thing I would point out maybe is that whether you do this laparoscopically or whether you do this through a small upper midline incision, it's important to remember you have to get out the vast majority of that infected necrosis, presumably infected necrosis. So whatever the technique is that you're comfortable with, that your institution supports, that you have a high volume of, is probably the way to go. Beautifully done.
Yeah. Well, so we saw him back in the office for follow-up after discharge at 10 days. So 14 days after his laparoscopic necrosectomy. He'd been having some kind of subjective fevers at home, and his PO intake once again wasn't great. And he said that every time he ate, he felt horrible. I was, yeah. And so his BUN was 40 and creatinine 1.4. So he was pretty dehydrated, and his white count was 12,000. And so we opted to bring him into the hospital at that time. Here is his CT scan. So there's either not the best necrosectomy, or the other thing is that he really, these stents, I blamed the endoscopist. The stents really were up in the cardia, and so it was like a direct shot every time he ate into this, the transgastric hole that they'd made endoscopically. But in any case, we had that to deal with. So, oh, and here's a coronal that looks worse. I swear it was all gone in the operating room. But there it is. And there's those stents. See how high they are. What do I do now? What do we do now? Nick, what do you think?
So Katie, let me ask you, and I think this is an important point too, if people are going to be doing transgastric necrosectomy, how did you do that technically? How did you leave those stents in there still? How big of a hole did you make in the back of the stomach? In my mind, which may or may not be right, the advantage that we have is that we can make a gigantic cystogastrectomy.
Yeah.
We can cut that thing. I put a big GI stapler with a seam guard and just staple that thing wide open to try to get to get as big of an access as possible. And then, I was looking for Brendan Visser. He's not on here, but those guys put like the guys from Germany and Lübeck, they do, the endoscopic stuff or laparoscopic stuff. They stick the scope through the stomach, into the stomach, back into the necrosis cavity, so they can really make sure that they get that thing cleaned out pretty well. Because I think, this is one of the problems you have, especially when the necrosis is down in the head. It's hazardous to get around to the right side of the vein, especially when the necrosis is down the root of the small bowel mesentery like this patient has.
Yeah. So we use the harmonic to make a very large posterior gastrotomy, and then use the scope, but didn't use the endoscope, used just a laparoscope to look around, an angled scope, but had a really hard time seeing around on the right side, as you said, to the right side of the vessels. But again, it looked great while we were in there. But I guess the question.
What do you do now? Yeah, the question is, what do you do now? I would probably err on the side of taking the guy back and opening him up and making sure you get it either cleaned, through the stomach. One thing that I've done in these situations, or when the necrosis is down the gutters, is to leave a big caliber JP drain in that cavity out the side. You can leave the cystogastrectomy intact, but you can get into that cavity, you can feel it and get into it and try to collapse the cavity down into the retroperitoneum. And then the question is how much tail is viable, with the disconnected duct too. But I think that trying to get the necrosis cleaned out, I would favor taking it back to the OR simply because of the right-sided head necrosis and the necrosis down the gutter. I mean, down the root of the mesentery. But you could also call your endoscopy guys back and ask them to help you out. We've had definitely several patients salvaged in this situation endoscopically without another operation. I think the main thing is don't fool around with it. Don't let them putter around with 2 or 3 or 4 endoscopies over several weeks. This needs to be cleaned pretty quick.
Chad, what would be your salvage method? Would you go back to the OR?
I would probably give our endoscopy interventional guys a shot at it, but I agree with Nick wholeheartedly. I'd stand beside them and we do it together very closely.
Yeah. My concern with the endoscopist is that I just made that anterior gastrotomy, 2 weeks before, and wasn't real excited about them, not just insufflating, but, kind of putting pressure against it with their scope and everything. So, Dr. Chaffee, any additional thoughts or?
Yeah, there's some comments be coming up too about how it looks like there are some windows for percutaneous drains for maybe a VAR down the road, and I think that is certainly something you could consider. I don't know if there wasn't a whole lot on the left that wasn't already accessed by those stents, but if you have a window on the right, you certainly could do that approach kind of down the road if the drain didn't temporize it. So I think that's certainly a possibility.
So I'm moving along because we have 3 minutes, but that's what we did. We put in a percutaneous drain in interventional radiology, and we're going to have them put in a feeding tube at this point because he really, was readmitted with failure of PO tolerance, and so we put in a jejunal feeding tube. And then we got a scan a few days later after the drain. And he was clinically doing much better. So now he's tolerating tube feeds and eating. And this drain was in there along with this couple of pigtail stents still. So now we got a drain in, he's doing better clinically. What do? Do we sit on it? Do we VARD it? I'll show you the problem with VARD is the distance between the abdominal wall and that cavity is pretty long. And so that, I thought, made it not a great VARD for me.
Yeah, this was a good move, getting the drain in there. That's a pretty good move. It looks like the drain is through the ribs, which isn't great. Flavio's on here, and those guys, the Virginia Mason group has managed the vast majority of their patients with this dual modality drainage. So I think I'd give this a shot for now. Irrigate the living hell out of that drain. You have an egress point through the stomach, so you can upsize. You got room to upsize the drain too. But again, I'm making the same point again and again, but you can't just let this be. You got to keep doing something until you get that necrosis cleaned.
So we upsized the drain and irrigated. Tim's about to cut me off. So, and this is when he came back to clinic 2 weeks later. We got a follow-up scan, and we got lucky. It worked. Great
save. We'll do the disconnected tail at the next session.
Yeah, exactly. All right. Well, thank you all so much for participating.
That was fantastic. Thank you, Dr. Morgan. Thank you to our panelists. These pancreatitis patients, as we all know, are some of the most challenging patients that we can deal with, and many of them are around for many weeks and months. So thanks again, Dr. Morgan. So our next section is going to be on an equally challenging topic, bile duct injury. And we're delighted that Dr. Winslow from MedStar Georgetown University is here with us tonight to help moderate this session. Emily? I don't know if can you hear me? Emily, you still on mute? Let's see.
Sorry about that. Okay, sorry.
Okay.
I was trying to
No
share
problem.
the screen at the same time. Okay, give me 1 sec. All right. Great. Well, thank you very much for the invitation, and I really appreciate the opportunity to present and discuss an interesting case with our colleagues listed here. So Dr. Weber is joining us from Madison, and Dr. Cleary from Rochester, and we're very fortunate to have Dr. Mercado from Mexico City. So and I'm in DC, as you said. So I thought we would just start by discussing a case much as Dr. Morgan just did, and Then I'll ask for comments as we go along from each of you. So this is a case of a 72-year-old woman who previously was quite healthy and presented with some nausea and abdominal pain and was found to have some mild hyperbilirubinemia, and on ultrasound had some gallbladder stones. So an ERCP was done at an outside facility, and a small stone and some sludge was extracted. And I'll show you that image in just a second. And then 2 days later, she was scheduled for an inpatient laparoscopic cholecystectomy. She was healthy with the exception of some mild diabetes, no real surgery before, and socially there were really no comorbidities, and she was physically quite vigorous. This is her pre-operative ERCP at the time of the stone extraction, and we'll come back to this, I think, in a little bit. So her laparoscopic cholecystectomy was described as really uneventful in terms of the initial findings. There wasn't much for inflammation, but they did think that there might have been a fistula between the gallbladder and the duodenum. And then it sounded like things were proceeding normally until bleeding was encountered. And they were unable to control this laparoscopically and converted to open and repaired what was thought to be some arterial bleeding, and then they completed the cholecystectomy. There was a very difficult initial hospital course. Her transaminases were between 3,000 and 5,000 initially. She had acute renal insufficiency and some effects of anemia, and unfortunately had a cardiopulmonary arrest on the 4th postoperative day, from which she was resuscitated, and then got a number of studies, as you can imagine. Was in the ICU on a ventilator, was eventually on CVVH for renal failure, vasopressors, and had an ischemic CVA with some motor deficits that were fairly dense initially. So this is an early, well, actually, this isn't one of the earliest scans because those were all non-contrast, but this is one of the first contrasted scans that she got several weeks into this. And what you can see here, obviously, is some free fluid, or, most likely bile. And then you see this infarct of the posterior section. There's a lot of clip artifact, unfortunately. It's really all in the upper abdomen. There's really nothing in the lower abdomen. So she was at the outside hospital for about a month, at which time it was noted that her drain became increasingly bilious, and the amount of output was increasing. Her serum bilirubin was about 8 or so, in that range, up and down, and an ERCP was performed for that reason. And here you can see the ERCP with some contrast extravasation, the portal clips. This is a feeding tube that you see here. And at that time, it was apparent to them that there was a significant biliary injury, and request for transfer was undertaken. When she arrived, by this point, so we're like 4.5 weeks out from the initial operation, she's hemodynamically normal, off of vasopressors, but still ventilated. She's on HD, and she has still some significant deficit from the CVA and is not able to participate, is still quite confused. In terms of local regionally, her bilirubin was about 3. She had a single percutaneous drain in, which had obvious bilious output, which appeared to be of kind of moderate volume in the 400 or 500 range. And we were able to obtain her old CT and ERCP, which I just showed you, and then got repeat imaging. So this is her, one of the initial scans after she arrived, and you can see she has persistent collection in the right upper quadrant here, although better. And what may be harder to appreciate with the scans showing this way is that the infarct of the right posterior liver is involuting some, and there's significant hypertrophy already in this time, as you'd expect of the left hemiliver. So we have hepatic infarct involving all of the right posterior liver. So segments 6 and 7 are both infarcted, and there's evidence, and you can see this on a number of series, but of ligation or occlusion of both the right posterior portal vein and the right posterior arterial branch in the setting of what appears to be a pretty significant and high bile duct injury. So the questions for the panelists, and I think maybe we'll just go in order that I see you here, is what factors do you consider when faced with a bile duct injury, and not just a vascular biliary injury, but one associated with concomitant hepatic infarction? And then what would you have done both initially, if you were in the initial presentation, or a month in on transfer? So maybe I'll start with Dr. Cleary.
Yeah, thanks, Emily. That's a great case and very unfortunate for that patient. So I think whenever there's a vascular injury that occurs, and certainly, with associated infarction, I think my mind switches from a very, looking to get an early repair done to a very much a delayed repair. This is a situation where the degree of infarction and the degree of biliary ischemia is going to evolve. You're going to prioritize controlling sepsis. And so I'm kind of going into a go slow mode, really trying to prioritize, controlling sepsis and further assessing the injury. But this would not be a case where I would sort of push for early transfer and be thinking of early repair. This is going to be a sort of a much slower road. I think the key, I don't know, it's hard to know, be the sort of Monday morning quarterback on these, but I think that the only thing to point is that we know that the outcomes of these patients are better when transfer is early. So obviously I think, the earlier the transfer occurs, probably the better. It worries me that it was about a month afterwards that they figured out there was a bile duct injury, when I think everyone on this call probably would have figured it out much quicker.
Sure. And then Dr. Mercado, what do you think about when would you do early resection for a hepatic infarction in this setting of a bile duct injury?
Yes, good evening to everyone. I agree with Dr. Cleary. Thank you, Dr. Wendell, for inviting me. I agree completely with Dr. Cleary. This is a very, very difficult case in which the liver infarction has played a major role for deciding the repair. In these cases, in which the complete posterior right lobe is disconnected and is non-functional, I think it's difficult to decide what to do in the next days. I have to see if there is no multiple organic failure. In this case, I would put a drain in the left duct, percutaneous, in the left duct, and wait so long so to watch what happens with the right lobe. I have seen, there are not frequent cases, but I have seen this type of injuries, and I suggest waiting with the left lobe drain, with the percutaneous drain, and wait so long as possible to stabilize the infarction of the right lobe. In some instances, I have found that the lobe shrinks completely, and in other cases, very few, I have to do to remove the right posterior duct commitment with the left hepaticojejunostomy. So wait so long as the patient stabilizes, has no multiple organic failure, has no sepsis, and plan biliary reconstruction, side to side, hepatojejunostomy with the left duct, and in this case, looking for removal of the right posterior lobe. But I will wait several days till the patient goes in a stable condition.
Great. All right. So I think we'll go on to the next data so we can show what happened with the drainage. So systemically over the next several days, the patient continued to be fairly stable, was able to be on some nutrition and weaning and otherwise well. And we placed both another percutaneous biloma drain and a PTC. So this is the picture from the left-sided PTC, as you suggested. And this coil is in the biloma cavity. It's extrabiliary, extrahepatic in this large cavity. And here's the prior biloma drain. What you might notice as well is there's some bile spillage from the capsular placement here, which later gets a percutaneous drain as well. So the PTC that was placed drained well, about 500 cc's a day, and the biloma drain changed significantly from about 800 to 200 cc's a day. The bilirubin was normalizing, and the patient was making slow improvement, but still quite ill, on dialysis, on the ventilator and with some residual CVA. So the patient was brought back for drain injection. So this will be a drain study to try to help identify the pattern of biliary injury. Here's the left-sided drain here that I was talking about at the site of the capsular biliary leak. And here you can see some of the right posterior ductal system. But importantly, on this cholangiogram, we see really no filling of the right anterior system. And so this was despite kind of, there was a CT cholangiogram here as well. And we, no matter where this tube was placed, we really couldn't get the anterior ducts to fill, even though they did fill initially, as you saw in the initial cholangiogram. So the right-sided ducts are separated, and we could tell from the preoperative ERCP that the right posterior duct drained into the left duct. And so that appears to still be communicating, but the anterior one is only communicating with the biloma cavity. So the question really was exactly what was the preoperative pattern. The ERCP wasn't quite good enough to tell, and I couldn't tell if what happened was something like this or more like this. And so we were trying to sort that out. So let's see, Dr. Weber, I think we'll start with you. So how do you proceed with identification of all the ducts preoperatively when it's difficult? Like what adjuncts can we use to this standard cholangiogram, fluoroscopy, and then how do you handle it when all the ducts really can't be accounted for preoperatively?
So I would just start with a couple comments just because we have all level of learners here. I mean, I think one thing when you showed that ERCP, just to remind the group, if you're in the middle of a difficult lab chole, go back and look on whether it's an MR or an ERCP. And many times I think learners in the OR maybe have forgotten that there's some biliary imaging, and it's always good to look at that when you're having a difficult laparoscopic cholecystectomy because it does give you additional information about what you're seeing. And I would just follow up slightly on this, the question about the liver infarct, just adding that I think I agree completely with Dr. Mercado and Cleary in their comments, but that situation changes if that infarcted liver gets infected. And then that becomes a completely different scenario and I think leads you in a different pathway. Frequently that liver will just involute with time and you won't need to do anything with it at all. But if it gets infected, I think frequently, probably most frequently, you're stuck having to resect that. I think trying to identify these ducts is extremely difficult, and what I think we have increasingly relied on is the use of CT cholangioscopy, where they're just essentially doing a tube check with the drains that you have, trying to identify the intrahepatic anatomy of the biliary tree. Sometimes, depending on what you have, that might be obviously the best thing, using your PTC for that identification. But if there's an external drain, a surgical drain or an external IR drain, you can try to inject through that and see if anything lights up in the liver as well. But I think looking at that three-dimensionally with a CT is very, very helpful. How to handle ducts that can't be accounted for preoperatively is really difficult. And I think sometimes for these very, very complex patients, and you could not get a more complex patient than this one, it's a matter of just repetitively seeing whether, you know, EOVIST MR, CT cholangioscopy, preoperative MR, like matching all of those things together to try and really understand that. And sometimes you're stuck operating on people when maybe you don't have a complete understanding just because our imaging can be so limited. So I think using all those modalities, because some will work in some settings and some will work in others, is what I would recommend. And I'd love to hear what the other panelists' thoughts are on that.
Sure. How about in Rochester? How do you handle it?
Sure. So I think, you know, one of the things that I'm thinking about in this case is there are occlusive injuries and there are transection injuries. So, you know, I wonder here whether we might have a combination of both, where the right anterior duct might be occluded by a clip, but yet the left and what's left of the right posterior might be draining into a cavity. So I think the idea of going back to your imaging and seeing if there is an occlusive injury of your right anterior duct, that might be evident on your imaging. And it might take another drain, another transhepatic drain to drain the right anterior. You certainly probably want to do that because that'll allow you to save parenchyma, and you can use that as a guide. You obviously got a terribly complex injury. So I think that, going back to cross-sectional imaging, ultrasound, CT would be the way to go. And I'd try and find that duct. But again, there are cases where you have to go for intraoperative exploration, but be very deliberate about it and know that you're identifying all of the ducts and you're using intraoperative cholangiography or probes to do that. I guess one of the questions I would have is that obviously, Emily, you're quite fortunate to have an interventional radiologist who was able to get a tube into a non-dilated duct. But for people who might be at centers where their interventional radiologists aren't that facile or that confident, what options would people suggest?
I think that's a great question. And Dr. Weber alluded to injection of the percutaneous drain as a way to highlight the intrahepatic system. And if it'll fill that system, I think that's what I think is helpful for the interventional radiologist. I know, Dr. Mercado, sorry, go ahead.
Just to follow up on that as well. I think if you get a patient transferred and they have a either surgical drain or an IR drain that's sitting anywhere near the porta hepatis, if that fibrosis over time, as that fibrosis, I think when you do the tube check and inject that with contrast, occasionally I've been in the scenario where they then can fill the intrahepatic ducts, and the contrast in the intrahepatic ducts makes a PTC possible. And so if you have good IR, which is a big if, and I think, Sean, that's a really good point. For many places, this is going to be the limiting factor. But there are some tricks that I think you can do, particularly as that fibrosis happens around the drain, because this is clearly a patient that nobody wants to operate on up front.
I think that's a fair summary of how we felt. Okay, so I'll show you. This was the pre-op ERCP, and I think it was extremely helpful, even though it's often difficult to obtain the fluoro from an ERCP. We really you could see the wire coming off of the left duct up the posterior system, and you could see the anterior duct inserting quite separately. So this really helped us when we were trying to map this out on the cholangiogram as to where to expect each duct. So this is, we brought the patient back to IR, and I think this is just an example of the persistence and kind of continuing different strategies until you can figure it out. But injecting the biloma enough, we injected both this drain as well as had a wire up and higher, and we're able to cannulate this anterior duct from the biloma cavity. So this catheter is now going up the right anterior duct and could at least show us where it was draining. Now, we weren't able to keep this tube there long term, which is what we'll get to next. And you can see this is just a standard catheter with extra holes, and you can see it's coming over the left duct into the biloma cavity and then up the right anterior drain, or the right anterior duct, I'm sorry. And this is the posterior ductal system, which is draining through this upper part of it. So let's say, Dr. Mercado, what percutaneous strategy do you use to durably drain, the biliary output when there are multiple ducts? Would you have converted this to a U-tube? Would you leave it like this? Would you put a second PTC in using that? And how do you manage the patient with a high output biliary drain?
Yes, these cases are extremely difficult. I mean, perhaps the cholangial resonance can help us to delineate anatomy. In some instances, although the ducts are disconnected, you can see them. But I think in this case, for me, the question is how much of the liver have I to remove? Because these ducts, in my experience, are very, very difficult to anastomose. And if you can anastomose them, even with a stent, in transanastomotic stent, they have a bad prognosis. They close. They're extremely, extremely thin, extremely difficult to maintain patency of these very small ducts. So I will only think and wait to assess how much liver I have to remove, if only the right posterior or the complete right lobe. Because if you see and can put a drain in the disconnected right anterior duct, you only give life to these two segments, and there's impossible. This externally biliary fistula is extremely difficult to manage because the ducts are so small that you cannot handle them with an anastomosis. So I will, in some way, only wait to stabilize the infarction of the liver if there is no sepsis, no infection, and only to know how much of the liver I have to remove. In this case, I think I will suggest to do a formal right hepatectomy and a left side to side hepatoileostomy with, I think it will be with a good prognosis with compensatory hypertrophy of the left lobe.
Would you make that decision for right hepatectomy preoperatively or intraoperatively based on what you found from the ducts?
I almost tell the residents that perhaps we'll take this decision intraoperatively, but I will plan it before. In the informed consent, I will explain the patient it's extremely difficult to obtain a patent anastomosis of these small tiny ducts. The evolution and final result of this separated anastomosis of these ducts will be very difficult. So I will suggest to do a formal right hepatectomy and a left hepatoileostomy.
All right, I think let's go on to the next and we can have some more discussion about that. So the patient really, it was about 6 months total from the time of her injury that she was ill. She eventually got off of the ventilator, was decannulated, got off of dialysis, her neurologic defects improved, she was able to get home, and she was able to eat again. And we had a GJ tube that was already in place and we're refeeding her bile throughout that time. Her infarct really involuted pretty significantly, and she had gotten several tube cholangiogram studies, and including the day prior to surgery, she was brought into the hospital for tube repositioning and re-imaging prior to repair. I'll tell you about her operation, then we can discuss whether this was the right thing. But she had a lyse of adhesions, and she did have some significant duodenal adherence or attachment. And as I told you before, they thought there was an initial fistula, and I couldn't tell if there actually was a perforation that was contained, but this area was repaired. The hilar plate was lowered, and segment 4B was resected so that to facilitate exposure, because there was a very significant overhanging portion that was covering the porta. An intraoperative ultrasound was performed really to examine the right anterior liver to see if the ducts were dilated, since we really knew from the immediate preoperative imaging that we were not draining these ducts and that they were draining into the biloma cavity. So at the time of exploration, we found 3 separate ducts, and we needed to decide, should we resect or reconstruct? And I think Dr. Mercado just said he would probably decide this mostly preoperatively that we would reconstruct, but I'd like to maybe hear from both Dr. Weber and Dr. Cleary about this. And then, do you ever consider ligation of a segmental duct that can't easily be reconstructed? I'm sorry, what I didn't show you was this image. It turned out to be something like this. There was a left duct, the right posterior duct, and really there was a transection right at the two. They were still attached, but there was very little mucosa between the two. And then the right anterior duct here was pretty extrahepatic, but strictured at its orifice and not too far away from the right posterior duct. So we're faced with this. The right posterior liver was involuted and didn't appear infected, and obviously the patient was some time out. So we were faced with the decision of how to manage the ducts and the liver. So maybe we'll just take a quick poll. I think Dr. Mercado already said he would do probably a right hepatectomy and a left hepaticojejunostomy. That's, yeah, okay. Dr. Cleary, how would you approach this? You're on mute there.
Yeah, so I think that I would probably, I think the right posterior is gone. I think I would, definitely look to probably resect that and reconstruct it. For me, rather than try anything to try and reconstruct it. The real question I guess I would have to determine was whether the right anterior duct is salvageable. And obviously it would be nice to have some volumetrics going in. You presume that the patient's hypertrophied, but you'd want to know that you could get away with a right lobe and not put the patient into liver dysfunction. If the proximal right anterior duct is strictured, that would certainly worry me, because I think the only thing worse than a preserved segment is a preserved segment with a stricture and an abscess. that's going to become a long-term problem. So, so I would, probably try and preserve the right anterior if I could. But again, if there's that kind of concern and you don't think it's going to work, it's better off to go ahead with the right hepatectomy. I wouldn't ligate any ducts in this kind of in a delayed operation, because I think the field is contaminated, it's infected, and any duct that you occlude is going to turn into an abscess and create more problems. You're just going to have to end up draining that duct. So I would tend not to ligate a duct in this kind of delayed repair type of situation.
Right. Yeah, I should mention the volume on the left side was more than adequate given the hypertrophy. And the right posterior liver, was small. It really was not a significant portion of the liver. Okay, Sharon, how would you approach it?
I mean, I totally agree with the comments that have been made, and I think definitely converting something that isn't currently a liver abscess into a liver abscess is going to result in a bad problem. And with this complex anatomy and her long course, I think probably a right hepatectomy is the way to go here. Your question about do you ever clip a duct that can't be reconstructed, I agree in the delayed fashion completely with Dr. Cleary that that's going to result in an abscess. I think the time when you can sometimes clip an aberrant duct is when you get called into the OR for someone who's struggling with a bile duct injury and it's a small, what looks like posterior sectoral duct. I think you can get away with clipping that and it doesn't cause infection, but those would be really in very select circumstances to do it at the time of the recognized posterior sectoral injury. In this delayed fashion, I think you don't have a lot of choice.
Great. So we ended up opening the right anterior duct first to see if it could be salvaged. And since it was fairly long and extrahepatic, we were able to get up above that stricture and still be at the hilar plate. And then the right posterior duct and anterior duct were just joined because they were actually quite in quote close proximity at the time, and a single hepatocogegenostomy was fashioned. The preoperative drain was placed through the anastomosis, and then a post-op cholangiogram was obtained prior to tube removal. She's about 3 years out. She had an MRCP initially that looked fine. Has so far just been having annual LFTs, which are okay. So, I think this is really challenging to know when the right time is to do this and how much the patient can sustain. So in my view, I think reminders or lessons from the case is really just remembering how morbid bile duct injuries can be. Often it seems like, this will be okay, you'll just repair it. But these patients can really suffer, and as this patient did. And then getting patients through the acute phase takes patience. And I think that can be often hard to come by on the surgical perspective, because we're wanting to just get the thing fixed for the patient and the family who want to be done with this. And then the preoperative ERCP and MRCP, as Dr. Weber mentioned earlier, is really very valuable, and it's worth whatever hassle it takes to get it to help understand with your IR colleagues and imagers what you're looking at post-injury. And really with time, that patients really can recover and return to normal functioning. This patient is back out on the farm that she lives on and is doing quite well with her resumed normal activities of daily living. So Dr. Pollack, with that, we'll end right on time.
That was absolutely fantastic. Both your punctuality and the impressive case that you presented are appreciated. But seriously, that was a very challenging case and an excellent case, and only to choose tonight to have our expert panelists discuss it. It highlighted a number of different points that need to be considered when managing these complex biliary injuries. So if we're moving from one challenging situation to the next, Dr. Roca is going to moderate our next session, which is on what I think is really one of the most challenging cancers that we care for as HPB surgeons, a hilar cholangiocarcinoma. Flavia?
Great. Well, thank you, Dr. Pollack. Can everybody hear me and see the presentation okay? Give me a thumbs up.
Yes.
Perfect. Okay, so it's my pleasure to be here tonight. My panelists are Dr. Alexandra Ganji, who's a surgical oncologist at Cedars-Sinai in Los Angeles, Dr. Adil Khan, who's a transplant surgeon at Washington University in St. Louis, Dr. Kareem Halazoum, who's a transplant and hepatobiliary surgeon at Cornell in New York, and Dr. Paulo Urman, who's an HPB surgeon at University of Sao Paulo, and just as a side note, was my gracious host for the HPBA Travel Fellowship. So welcome and thank you. So to jump into the case. So this is a 50-year-old gentleman presented in a classic fashion, painless jaundice, dark urine, acolic stools. He was seen at one of our sister hospitals over in Eastern Washington that referred him into town for a liver mass seen on CT. The pertinent laboratory findings on presentation was a very elevated alkaline phosphatase, as well as liver enzymes and total bilirubin. And he did have a CA19-9 that was somewhat elevated, although again, in the setting of a very high bilirubin. I'll play for you the CT scan that you can look through. And you can see dilated ducts on both sides and what appears to be a mass in the central liver. He did get a pelvis and a chest CT that did not demonstrate any evidence of distant disease. So with that, I'll start just on what I see on my screen. So Dr. Ganji, any other imaging or staging you would like at this point?
You said he already had a CT chest and pelvis, which was negative.
Correct.
I typically favor doing MRI, MRCP to better evaluate, delineate the biliary anatomy, both intrahepatically and then what's extrahepatic. I do have some difficulty evaluating the vascular structures on MRI, but he already had a 4-phase CT, so I think that would be sufficient at that point. You can also consider an ultrasound, certainly.
Okay. Dr. Erman, anything different that you would do in Brazil?
We just do MRIs and angio CT to study the vascular anatomy.
Perfect. So I think this is the way, yes, well, most of us would look at evaluating these patients for surgery. So while cross-sectional imaging is important, I think you do need to get some sort of biliary imaging. And the highlighting in red, really depending on, and any invasive procedures, only depending on whether you need it, which we'll get to in this case shortly. Other things to consider as you're thinking about this patient is obviously biliary stenting, consideration of transplant, portal vein embolization, and others. So here you'll see the MRI, and you'll see here, again, you're demonstrating the tumor into the central liver with some extent, both into the right and left ducts. I don't know what you guys were used to, but we're certainly used to the Bloomgart clinical staging system to look at what the extent of disease was. And in this case, this was a T1 patient by the imaging. Dr. Halazoun, anything else you would do at this point?
So the bilirubin was 23.
23.9, correct.
The patient needs to be drained. But back to the MRI, was the right portal vein involved or not? I couldn't really see.
Yeah, no, the portal vein, there's no vascular involvement, either artery or vein.
Okay.
Can you tell us a bit about what your preferred route for drainage would be, and would you get a biopsy for tissue?
So I don't think you need one in this case because, the biopsying the tumor is inaccurate, as we all know. But I think it's institutional, although there's some data to suggest that percutaneous may be better than endoscopic. We would start with an ERCP. And if the ERCP was able to drain the patient adequately, that's great. There's, I think if the patient was across the road, and I think Mike is one of the attendees, he'd get a PTC first potentially, but we would start with an ERCP here.
And Dr. Khan, anything different in St. Louis? I think you're muted, Adil.
Start off with an ERCP as well. If we can get drainage that way, that's ideal. And brushings and check for fish at the same time. We wouldn't recommend doing a percutaneous biopsy. Endoscopically, brushings are fine.
Okay, so yeah, so we obviously have a very active GI department, and you can see here's the reconstruction for the MR of the tumor, as well as the initial ERCP images. Now, unfortunately, our talented endoscopists were only able to cannulate this right anterior duct, as you can see, and put a small-ish plastic stent in there. They were able to get some brushings, but they were just atypical cells, although they were FISH positive. So just as a quick review, the stuff that you guys had talked about as far as endoscopic versus percutaneous, I'm sure you're all aware of this randomized trial that was done in the Netherlands regarding the different routes of administration, which unfortunately was closed early due to an increased rate of death in the percutaneous group. Although if you'll notice, 56% of patients in the endoscopic group did require crossover into the percutaneous group. And this was highly flawed. I believe Dr. Votay's group actually wrote an editorial to this. And indeed, he did fail. So he actually developed cholangitis. Bilirubin did not come down, and we ended up having to put a percutaneous drain. And you can see here the access that was obtained on the right. You can see the plastic stent actually bridging the defect. And following this, we also put in a left-sided PTC because that, to me, was going to be the remnant. Dr. Ganji, any comments on this? Would you have done anything different in Los Angeles? The failed ERCP?
No, sounds about right. Sometimes we'll consider PTC initially if we're worried about getting an ERCP, getting a stent into that left-sided system if we need that as our future liver remnant. So sometimes we may have chosen that initially as opposed to doing the ERCP.
And how about Paulo? Does this help you plan your operation, whether it's right or left?
I think so, but we do prefer a percutaneous approach than the endoscopic approach due to sometimes risk.
Sure. And Kareem, right versus left, is there an easy way to tell from cholangiograms? And again, with no vascular involvement, you have the options.
I agree with your assessment that this is a right trisect and that you have to drain the left side.
Okay. And I see Adil's head nodding, so I'm assuming he concurs. Okay. Now, since I have both you transplanters on, the question's always resection versus transplant. And here there was a nice article in the Annals of Surgery with editorials written by Chuck Rosen and Dr. Nagino. And as Chuck mentions, that hepatobiliary surgeons and transplant surgeons are like otters that hold hands at night when they sleep, and they should be getting along. So starting with Dr. Khan, resection versus transplant in this case, I know WashU has a large experience.
In this case, it seems to be fairly straightforward resection-wise. So I would, I think, in resectable cases, resection remains the treatment of choice.
And Kareem, how about in New York?
No, this is a no-brainer. I think if it's resectable, you need to resect it. The data that you're showing from the paper is very interesting, but the paper is flawed because the 3 centers that were involved, including Adil's, are all relatively low waiting time regions. We don't have the same experience as Mayo Clinic or the other centers or Emory where I worked previously, where the waiting time is very short. Our patients drop off the list very, very often. So a lot of them don't get to transplant. So if they're resectable, resect them.
Okay. And Dr. Ganji, I know at Cedars has a very active transplant program. Do you guys hold hands at night?
We try.
Okay. All right. Very good. So we did feel that this was resectable as well. However, the liver remnant was too small. And so we did perform a portal vein embolization. And you can see just on these images, the hardware that was already placed in with the 2 percutaneous catheters as well as the endoscopic stent. And we prefer to do right-sided, and we do not routinely embolize segment 4, even for extended resections. And we don't routinely do hepatic vein embolizations. And again, I'm curious from the panel if anybody wants to jump in if they do that routinely or not, or in what situation.
We don't do it routinely, but when segment 4, yes, routinely for planning a right trisect, but the hepatic vein's not routinely. But if it doesn't grow, yes. But can you define too small?
We'll get to that. The preoperative volumetrics demonstrated a segment 2-3 of only 19%. Paulo, how about in Brazil?
We do segment 4 embolization as well, but we don't do the vein embolization.
Okay. Great. Well, here, as you can see the pictures, here's the FLR that went from 19% to 26%. We do like to wait about 4 weeks. And so we get a kinetic growth rate there of about 1.75, which to us is reasonable to proceed. And with the left-sided liver segment drained, there is some data to suggest that if your remnant is less than 30%, drainage is recommended. Well, what about the conduct of the operation? Dr. Khan, can you tell us how you think about going through this in the order of steps? This is just our approach that we do here.
Yeah, so no, I agree with starting off with the diagnostic laparoscopy. Definitely in high-risk patients, somebody who's at a high CA19 titer, you're worried that you might find metastatic disease. and then do a thorough staging. Just make sure there's nothing outside the area of resection that would be considered as unresectable. And then really spend the time just to make sure that the tumor really is resectable. I agree with the portal lymphadenectomy, excision of the bile duct. The vascular control is extrahepatic initially, as the bile duct is divided as you divide the liver. Caudate resection has been it's always a little bit of a controversy whether you should or you shouldn't, especially with right-sided trisect resection. But most of the time, the caudate does need to come out just because the drainage is a little strange, and you can get a better oncologic operation with that. It sounds like the veins, the portal vein and the artery were not involved, but we always assess them to see if that's something that might change the operation or might need a resection. And I think that's pretty much the sequence of events for us.
Dr. Herman, I know you've published a nice series on hanging maneuvers for these and using a no-touch technique. Do you still employ that in Sao Paulo?
Yeah, it's routine. But we routinely resect the caudate lobe.
Oh, interesting. Anybody different from Dr. Halazoun or Ganji? This is a right-sided tumor. Do you do it routinely for left-sided, selectively for right?
We routinely take out the caudate also.
Agree.
Okay, great. So this is actually not this patient, but I have seen, this is a different patient of mine that we did do a laparoscopy, and you can see what these plaques look like in the peritoneum that are not picked up by CT scan. And then what about your lymphadenectomy? Dr. Ganji, start with you. Where do you start sampling?
I typically start sampling at the common hepatic artery and then the portal vein and cystic and common duct.
Okay. And Dr. Halazoun?
Same.
Same.
I think there's a good paper from Tim Pollock recently that showed that you should routinely take the lymph nodes behind the head of the pancreas also, because often metastases go there first, but not necessarily the rectoaortic or rectocabral, like whether they station 16 and 14, I think you can avoid, but station 13 you have to get.
And Dr. Khan?
No, I agree with Kareem and with Alexander.
Yeah, so I actually do like to do a generous coker, and I actually do palpate the aortocabal space. And I don't routinely harvest those, but if they are enlarged, I do sample those. Now we'll talk about the nodal staging, which has changed a bit, but that's still considered out of bounds for this disease. So I do like to do it selectively. Paulo, any difference in Brazil? No. Okay. So this is actually a nice video that my former fellow, Dr. Bonds, of this case. I'm going to turn down the volume here. She just presented this at the IHPBA, and that actually is the video from this case. And you can see here the exploration, including, we didn't talk about intraoperative ultrasound, but I'm assuming all on the panel do use this to guide the resection. Anybody have any tips, operative tricks that they use as they watch the video that'll be helpful? I was always taught to obviously culture the bile duct and get that sent off.
Do you routinely send the distal margin of the bile duct for pathology or not?
I do. I think it's important to know that offhand, and you'll see that in just a second once I get these stents out of the way, because I think it's going to depend on what you do. For example, Dr. Khan, what would you do if this margin came back as positive? This is at the top of the pancreas.
You definitely have to try to go down as low as you can. I'm assuming that if you're as low as you can and still positive, then you have to consider whether you would have to do a Whipple along with it. But I think a lot of it would also depend on what your proximal margin is going to be like. So at that case, I would probably proceed with the resection and check the proximal margin and then use that information to make the final decision.
Got it. As you can see, we're controlling the hepatic artery and the portal vein extrahepatically, as you suggested, and then getting behind the liver, dividing the cable ligament, and then the right hepatic vein. Any tricks there as far as anybody like to do a hanging maneuver for this? I know we mentioned Dr. Urban's approach. Dr. Ganji?
Haven't done hanging maneuvers for a cholangio just yet, but some very large-sided HCCs.
Got it. How about Dr. Hausen?
Yeah, I hang. I have a quick question actually back
Yeah.
to what we're talking about. So what Adil mentioned is that if the margin towards the pancreas is positive, you'd still proceed with the liver resection? Because if it's an invertative cholangio, you're very unlikely to get margin on any side, right?
Yeah, if it was me, I'd have to really pause at that point and say, I'm not really gonna, if I do this big liver resection with leaving a margin behind would be problematic. I may actually stop at that point, do a biliary reconstruction. Here, just to pause real quick, this is actually the left duct, and you can see the tumor that's actually inside the bile duct, and we actually were able to cut that fresh and get a negative margin up at the top. And then in the end here, as was mentioned by all the panelists, we are resecting the caudate as well. One trick that I like to do is actually pull the percutaneous drain back into the liver so that I can use that later on to pass through my anastomosis. I don't know if others do that as well.
It's a good trick. I don't. You do it next time. We don't have that many percutaneous drains. They're usually ERCPs, so it's not.
Got it.
I use that routinely. I like it.
Okay.
We usually don't stent the
anastomosis. Yeah, there were some questions in the last chat about U-tubes. Anybody use U-tubes or Hudson loops? I know they're still described in the textbooks. Dr. Ganji?
I have not, no.
Adil?
U-tubes for bile duct injuries, but not for this.
But not for these. Okay, fair enough. So the pathology, here's the specimen. It did come back as a model-differentiated invasive adenocarcinoma, and it was associated with this precursor lesion, an intraductal tubulopapillary neoplasm, so ITPN, and it had extensive high-grade dysplasia as well as carcinoma in situ. There was intraductal tumor present in both the right hepatic duct, extending into the left and into multiple other bile ducts, and the invasive component was actually found in the caudate lobe. So in this case, it was actually, would argue for routine caudate resection. There were 7 lymph nodes, all negative for tumor. All margins were negative, and this was staged as a T1A and 0. So just as a quick review, ITPN are these new, it's a new entity really branching out of the papillary neoplasms of the bile duct. This is actually the largest series in the literature. It's about 20 cases, and it's really an overview from pathology, demonstrating again that invasive components are common in most of these. However, survival is actually quite good with resection, but it is a different molecular pathway that's thought to be KRAS independent, unlike the intraductal papillary neoplasm, which is KRAS dependent. So now just to review quickly, because I know our esteemed president, Dr. Pollack, was actually involved in the new revision of the AJCC 8th edition. You can see here that the nodal staging has changed so that it's not a location-based, but more of a number-based approach. So now between N1 and N2 is the number 1 to 3 or 4 or more. Also, the old Bismuth 4 classification is no longer considered stage 4, but it's stage 3. And this reflects, again, I think the talent we have of our surgeons that actually resect more of these. Have you put these into play, Dr. Herman, down in Brazil with the new staging? Has that affected your practice at all?
Indeed, we put it in our routine, but just the difference between the 4 and the 3B classification.
How about
regarding lymph nodes, we do the same as we did before.
We do the same. How about for the 2 transplanters? Because T4, the Bismuth 4s were initially almost always referred for transplant, but would you still do that given this new change, or would you attempt a resection?
I mean, any nodal positivity for transplants out.
No. We're talking about the extent in the biliary tree. So the Bismuth 4s, the real high lesions.
I don't think it would change. The issue with the transplanted patients is that it's getting them to transplant. It's not, the data is conflicting. Let's just leave it at that. It's hard. It's very hard to get the cholangio patients to transplants in our institution. It's impossible, almost impossible, because the majority of them drop out.
How about Dr. Khan at WashU? I know I've sent a couple your way.
So if we thought that there was a high chance that we would have a positive margin with resection, we would probably, and the patient was otherwise a good candidate for transplant, we would probably pursue the transplant route.
Okay. And Dr. Ganji in Los Angeles, do you guys have combined tumor boards or discussions for these patients, or does one service burden the load more than the other?
No, we do have a combined multi-D discussions, and we do have a transplant protocol that follows the Mayo transplant protocol.
Great. So of course now the new player on the block, adjuvant therapy. So I'll start with you, Dr. Ganji, since you're already on my screen. What would you recommend for this, healthy patient, margin negative, node negative resection?
Yes, I mean, I think based on the fact that you just reviewed the pathology and it's a tubulopapillary, it seems as though it has fairly good survival just with resection alone. I think you can argue that there's no role for systemic therapy. I think the best trials we have show that, in certain patients, recurrence-free survival is equivalent between patients who get chemo and not. And then the bill cap was underpowered, but I favor in patients who have high-grade features, positive margins, node positivity, lymphovascular invasion. Those are patients I think no question get adjuvant therapy. I think in a patient like this, you can omit therapy, although it would still be well tolerated.
That's fair. I just put up the sort of the 4 biliary trials of which you mentioned the bill cap, which perihilar tumors are actually a smaller fraction of those patients. I don't know, Dr. Herman, what would you recommend in Brazil? I know you have an active medical oncology group down there.
We do adjuvant therapy in all patients with positive lymph nodes or positive margins. And the protocol they're using now is JAM with capecitabine.
With or without radiation? Because obviously you can see the SWOG single arm trial did use that exact combination, but did follow it with radiation.
The protocol we're using now is without radiation.
Without radiation, okay. How about Dr. Khan, WashU? What do your oncologists tell you?
It can go either way, but I think, you can go either way.
Okay, and Dr. Hausen?
We do radiation, not in everybody, but sometimes.
What about in this case?
I mean, can you go back to your pathology? I think it had vascular invasion, right?
No lymphovascular invasion.
I mean, this is. I have to tell you, I've resected one of these, and 5 years later, the tumor came back. So, and the patient didn't get any chemo. So now, anecdotally.
So you would do it?
I think so.
Okay.
We understand this entity that well.
Yep.
And probably a diffuse disease of the bile ducts. So I don't know if giving the chemo would prevent it from coming back on the other side.
Yeah, no, fair enough. So this is what we have to date. So we did not actually recommend we did not recommend any adjuvant therapy for this patient. And the main reason was, one is this was 2 years ago, so obviously bill cap was just kind of coming into fruition. But for all the things that were mentioned by the panel, including the favorable features, we did not feel that it was necessarily indicated. He actually did come into clinic last week and is currently NED after 2 years with a normal CA19-9. Although I share your concern, because my only other patient with this did recur actually about 5 years out. And so it can happen. Now, whether the chemotherapy or any adjuvant therapy would have prevented that is hard to know. Just one last thing before we move on. I just want to make you all aware that the operative standards for cancer surgery is going to be coming out early next year. Several HPBA members have contributed to this, and this will include operative standards for hilar cholangiocarcinoma as well as other liver tumors. I'm going to stop sharing for a second here and just see if there's any comments in the chat.
Thank you so much, Flavio, and the panelists for a great discussion. I have one quick follow-up since we have 3 minutes, just to clarify, as some of us have been discussing this offline, not in the chat room. You cut the distal bile duct and the margin is microscopically positive. Did you imply then that you were just going to sew a roux limb to the bile duct and leave all the tumor behind, and you were not going to do an extended right and the bile duct resection with a positive margin on the pancreas side and radiate afterwards?
Yeah, what I would do is I try to keep digging the bile duct out of the pancreas. If I can keep digging it out and get to a negative margin there, yes.
You don't. Let's say it's an R1.
Well, I have real struggle with leaving positive disease in the pancreas. I think putting somebody through an extended hepatectomy in that scenario, I don't think radiation is a substitute for an optimal operation. So no, so if I could not get a clear margin, and that's why I do that first, because I want to know right away what's going to happen.
I think many of us would disagree with you. And when you get to Oregon, meet up with your radiation oncologists and become friends with them. They do a lot of valuable things. Anyone on the panels?
I think it's controversial, but I tend to agree with Schimmel. If that margin's positive, I dig it out, and if it's I tell the residents or fellows, it is what it is. It is what it is. You know what I mean? And then I proceed.
So actually,
I don't know if that's right.
Because in Brazil, there's very big proponents for hepatopancreatic duodenectomy, doing a Whipple and liver resection. As Schimmel knows, we've seen a lot of cases from a different group where people do both at the same time, although the outcomes are questionable. No, okay.
Oh, no, agree. I think in Asia, it's a very, and of course, Dr. Nagino's group has got a lot of experience in this. I just haven't seen a lot of good data prospectively, but again, you have to individualize therapy sometimes.
Just want to make sure we're on the same page. Well, thank you, everyone. I'm going to hand it over to our president, Dr. Pollack, for the final words. And